Welcome to the second NephroTube online lecture about acid base and electrolytes disturbance. This lecture we will discuss in details the practical approach for the diagnosis and the management of hypernatremia. The previous lecture was about hyponatremia. You can find the previous lecture and all other lectures of NephroTube on nephrotube.com. You will find the PowerPoint on nephrotube.com. You will find the recorded versions of our lectures on our YouTube channel, NephroTube, which are available in both English and Arabic languages. You can join our Facebook group and like our Facebook page to follow the activities of our NephroTube team, and also you can follow us on Twitter. Back to our lecture. As we all know, and as we mentioned before in the hyponatremia lecture, that sodium is mainly an extracellular fluid ion, while potassium is mainly an intracellular fluid ion. Hypernatremia is diagnosed once the serum sodium concentration is more than 145 milliequivalent per liter. As we mentioned before also in the lecture of hyponatremia, that plasma osmolality depends on, in its equation, depends on the sodium, glucose, and urea or blood urea nitrogen. So when there is hypernatremia, there will be always hyperosmolality. So hypernatremia always equals hyperosmolality. But actually the opposite is not true. Not all hyperosmolarity will equal hypernatremia, because there are other factors that affect the osmolarity equation. Even there may be other hidden osmotic active substances in the body that are not in the equation that may affect the measured osmolarity. So in general, hyperosmolarity is not always equal, or maybe sometimes equal hypernatremia. I will discuss hypernatremia through this case to use my approach to diagnose and treat this case. This case is of a 74-year-old man who is admitted by hypernatremia. Let's see what is the presentation of this old man patient. This patient presented with lethargy, disorientation, and confusion. So, as it is clear from here that hypernatremia is presented by central manifestations, and this is what I want to clarify. Why hypernatremia is presented by neurological symptoms? Actually, all sodium disorders, whatever it is, a hypernatremia or hyponatremia, will present by neurological symptoms, as the change in the serum sodium concentration will affect the serum osmolality, which will affect the water content in the brain by increasing its size or decreasing its size, depends on it is hypernatremia or hyponatremia. Let's see here what is happening in case of hypernatremia. In case of hypernatremia, what I will discuss now is the opposite to what happened in hyponatremia and that we discussed in past lecture. In hypernatremia, there is an increased concentration of sodium in the plasma, which will increase the osmolality of the plasma. So this will osmose water from cells out into the plasma. So the brain cells will lose water. This will make the brain cells to shrink, and this what causes the neurological symptoms secondary to hypernatremia. Does the onset of the development of hypernatremia affect the severity of the symptoms? The answer is yes. The same as the case in hyponatremia. Although the acute change, even in any change in our body, the acute change effect is mainly more aggressive than the chronic gradual change. As usually in the chronic gradual changes, there is some sort of adaptation from our body, whatever the mechanism of the disease. So in case of acute hypernatremia, you will find more severe symptoms as nausea, vomiting, lethargy, irritability, weakness, even convulsions and coma. While in case of chronic hypernatremia, slowly developed hypernatremia over 1 to 2 days, we'll find less neurologic signs and symptoms because of what is called the brain adaptation that we discussed before in the cases of hyponatremia, and I will discuss again later in this lecture in case of hypernatremia. The brain in chronic hypernatremia will adapt itself so not to lose water that much as in cases of hypernatremia. So this will lead to less severe symptoms in the form of weakness, nystagmus, disturbed sensorium, and etc. That was my introduction about the main presentation of hypernatremia and the main cause of neurological symptoms of hypernatremia. So now to diagnose the cause of the hypernatremia and how to treat hypernatremia, in every patient we have to answer 4 questions. Question 1, is the patient hypernatremia related to water deficit or gain of sodium? Question 2, we have to calculate water deficit for the patient. Question 3, what is the choice of fluid of administration? Question 4, we have to estimate the reduction in serum sodium for every 1 liter of fluid that we will infuse in 1 hour. So this will be my talk outline through the rest of the lecture. Let's start to answer question 1 regarding the case that I presented. Any patient who developed hypernatremia, he may develop hypernatremia due to water deficit, he lost water, so the sodium is concentrated in the plasma, or he may develop hypernatremia because he gained more sodium. So for the development of hypernatremia, there must be 2 steps. The first step is the generation of hypernatremia. This is by either gain of sodium or loss of water. But there is an important step for the hypernatremia to be developed, which is the maintenance of hypernatremia. For hypernatremia to be developed, an important factor that there is a limitation for the water intake by the patient because of failure to sense thirst or unable to ingest water, as in cases of ICU. The patient is admitted in the ICU, or whatever the reason that the patient can't access water, or the patient in a disturbed level of sensorium, so his water intake is decreased. So for the development of hypernatremia, decreased water intake must be present to maintain this hypernatremia. And by the way, hypernatremia is less common than hyponatremia, because actually any patient or any person who becomes hypernatremic, this will activate the thirst center and activate thirsty, and the patient will start to drink water, which will correct hypernatremia. So the generation of hypernatremia by its own is not sufficient to develop hypernatremia. There must be the maintenance phase, which is a problem in fluid intake. So all the causes of hypernatremia at the end will cause hypernatremia by one of 2 causes, either by loss of water or gain of sodium. The flowchart in front of you now is the classical flowchart for the diagnosis of hypernatremia. I will go through it, but after that, I will try to handle it in more clinical, practical way. Hypernatremia causes classically can be classified according to the volume status of the patient, and as we discussed in the lecture of hyponatremia, that the sensitivity and specificity of the diagnosis depending on the assessment of the volume status is not high. So as we discussed in hyponatremia, we try to find other way to diagnose the cause of hypernatremia without the dependence mainly on the clinical assessment of the volume status. But here in hypernatremia, there is no clear approach for the diagnosis of hypernatremia without the use of the volume status. So we will go through the approach and then we will try to handle it more. The cause of hypernatremia may be divided into hypovolemic hypernatremia. In these cases, the patient will lose excess water, and the loss of water may be extrarenal, as in case of vomiting, diarrhea, sweating, burns, GIT fistula, etc. Or the patient is losing water by the kidney, as in cases of osmotic diuresis, use of lobe diuretics, or post-obstructive diuresis. Post-obstructive diuresis, as in patients with PPH, that you inserted a catheter for him, or a patient with a stone that was causing a hydronephrosis, and the stone passed away. This will cause a polyuric phase of ATN. All of these cases cause post-obstructive diuresis, and this may cause hypovolemic hypernatremia. And by the way, you will find vomiting, diarrhea, you will find osmotic diuresis as in case of hyperglycemia, mannitol. You will find loop diuretics. All these causes, you will find them in the causes list in both hypernatremia and hyponatremia. So vomiting, diarrhea, osmotic diuresis, loop diuretics, which all classified as water loss. So water loss may cause hypernatremia or hyponatremia. Depends on what? Depends on the water intake of the patient. If the patient is losing water, and in vomiting, diarrhea, osmotic diuresis, loop diuretic, and in this water, yes, it is a hypotonic. The patient is losing also salt in this water mainly, especially in osmotic diuresis and loop diuretics. So if the patient is losing water and he is drinking pure water at the same time, this will cause hyponatremia. But if the patient is losing water by renal loss or extrarenal loss, and the patient is not drinking water, there is no water intake, and the patient is dehydrated and his blood volume is concentrated, this may cause hypernatremia. So hypovolemia or cause of hypovolemia may cause hypernatremia or hyponatremia depending on the water intake of the patient. Regarding other causes of hypernatremia, hypervolemic hypernatremia occurs in the cases of saline infusion, sodium bicarbonate intake, hypertonic dialysis, salt water ingestion, or endocrinal disorders as primary hyperaldosteronism or Cushing syndrome, where the aldosterone is very high and cortisol is very high in these cases. And you know these hormones have a good or a powerful reabsorbing power of the sodium from the distal tubules. In all these cases, the excess of the sodium in the plasma will associated with increase of water volume also, which will cause hypervolemia. But here, the increase of the sodium is more than the water increase, which will cause hypernatremia. Euvolemic hypernatremia, we will see it in diabetes insipidus, and we will talk a little bit about diabetes insipidus now. But in diabetes insipidus, the patient, there is a problem in the antidiuretic hormone of the patient. Either there is a decrease of the release of ADH hormone from the pituitary gland, or either there is a resistance or decreased response of the kidney for the normally released ADH hormone from the pituitary gland. Another euvolemic hypernatremic cause is a very rare disease called hypotepsia or adipsia, where there is a defect in the thirst sensation of the patient, and usually this is a disease of exclusion, and it is very rare disease. Another way to differentiate between these cases according to the urinary sodium level, but actually alone, it is not maybe not be sufficient to diagnose the case, but let's go through them. Yes, usually in extrarenal causes where there is extrarenal loss of fluid, the kidney will try to reabsorb sodium to compensate the water loss and to compensate blood pressure. So in these cases, you will find urinary sodium less than 20. The opposite, if the water loss is mainly due to renal cause, you will find also some sodium loss through the kidney, but usually the water loss is more than the sodium, causing hypernatremia. And in this case, you will find the urinary sodium is more than millimole per liter. In cases of eovolemic hypernatremia, you will find the urinary sodium more than 20, and in cases of uh, hypervolemic hypernatremia, we'll find that the sodium in the urine is low or high, depending on the cause. Mainly in the endocrinal causes, you will find the sodium in the urine is low, while in the infusion of salt, whatever the way, you will find the urinary sodium is high. Also, in hypovolemic hypernatremia, this is an important point. You will find orthostatic changes, and in hypervolemic hypernatremia, you may find edema. Okay, let's go through the causes by a more easier way, more easier approach. Most of the causes of hypernatremia will be clinically clear without any approach. As we mentioned this before, also in the cases of hyponatremia. Here, if the patient is already on loop diuretics and you found him a hypernatremic, so usually the cause is loop diuretics. If there is a history of obstruction and there is a post-obstructive varices, usually this is the cause, and this also causes may be very clear from the start. Also, the drug history of the patient is very important. So most of the cases of hypernatremia, the cause is very clear. But some causes may need intervention or a practical approach to diagnosis. Osmotic diuresis, usually if the osmotic diuresis is due to mannitol infusion or whatever, the history will be clear. If it is due to hyperglycemia, this will appear in the investigations. But actually, it may be due to a hidden osmotic substance or hypertonic substance that the patient is taking in his diet. And I will show in a while to you an important clinical teaching case of osmotic diuresis and polyuria that they discovered later that it was related to the diet habit of the patient. In primary hyperaldosteronism and Cushing syndrome, you will need intervention, practical approach to diagnose, and in diabetes insipidus also you will need an approach that I will mention now. And regarding hypotipsia, it is a diagnosis of exclusion. In case of primary hyperaldosteronism and Cushing syndrome, usually you will find with hypernatremia, you find the hypokalemia, you will find metabolic alkalosis and hypertension with the patient. And actually, the diagnosis of Cushing syndrome, primary hyperaldosteronism, will be more related the practical approach of hypokalemia that we will discuss in the next lecture. Next lecture, we will discuss how to diagnose hypokalemia, and this will lead you also to the diagnosis of primary hyperaldosteronism and Cushing syndrome. So these endocrinal diseases you can diagnose through the hypernatremia at the beginning of your approach or through hypokalemia. Regarding osmotic diuresis, you have to check the blood glucose level, but as I told you, there are some other hidden causes that cause osmotic diuresis that we will mention now. So usually, not usually, always osmotic diuresis will present by polyuria, and diabetes insipidus, where there is a defect in the effect or the action of ADH, whatever the cause, will present also with polyuria. So we have now to discuss the approach for polyuria. So for general panoramic view of this approach, you will find mainly the causes are totally clear. endocrinal causes will be associated with hypernatremia, hypokalemia, metabolic acidose, and hypertension. The other causes, which are osmotic diuresis, whatever the cause, diabetes insipidus, will be associated with polyuria, and we will discuss in a few minutes the approach for polyuria. Back to our patient to answer question one. Is the patient's hypertension related to water deficit or gain of sodium? By clinical examination of our patient, who we said that he is 74 years old and presented with a sodium of about 168 milliequivalent per liter. The blood pressure on admission was 170 and pulse rate was 100 in a supine position. But in sitting position, the blood pressure was 80 over 60 and the pulse rate increased, which means that the patient has orthostatic postural changes. And by the way, in the history of this patient, they found that he had vomiting. So the patient had orthostatic changes and hypovolemic hypernatremia secondary to vomiting. So in this patient, hypernatremia is due to water deficit rather than sodium gain, as the patient has orthostatic changes. Back to our approach, now we have to diagnose or have diagnostic approach for polyuria. I will talk about two approaches. The first approach, without the use of the water deprivation test, but this approach, or by another way, you cannot depend only on this approach. Please approach this approach just to give you a general suggestion or assumption about what the diagnosis will be. In a patient with polyuria, you can check the urine osmolality. If the urine osmolality is less than 250 or 300 milliosmol per kilogram, so the urine is totally diluted. So sure, this will be a diabetes insipidus where there is a large volume of urine and free water excretion. Look at the patient, even before water deprivation test, look at the patient plasma sodium. If it is more than 140 millimole per liter, yes, so this may be diabetes insipidus, because in diabetes insipidus, the intravascular volume is slightly decreased, although the patient is clinically euvolemic. But in primary polydipsia, where the patient is drinking a lot of water, his sodium level usually will not be more than 140. His plasma will usually be slightly diluted with sodium in the lower normal range. If the urine osmolality is more than 300, so the patient has renal concentrating defect or osmotic diuresis, and we will differentiate between those by measuring what is called osmol excretion rate that I will discuss in a few minutes. If the osmol excretion rate is high, this means that high osmolar substances are in the urine. This will diagnose osmotic diuresis, and if not, this will diagnose renal concentrating defect. So this is the second and the main approach that I suggest to use for the diagnosis of polyuria. It was published in American Journal of Kidney Disease in March 2016. And I suggest to you this article to read. It was about a case of female presented with polyuria that was misdiagnosed at the start as diabetes insipidus, and she received desmopressin with no good response to desmopressin. And with further evaluation of the case, they found that the polyuria of the patient was related to a diet habit, that the patient intake of protein and osmoles was very high, and with diet modification, the polyuria disappeared. And from their case, they suggested this approach for the diagnosis of polyuria. Polyuria, defined as urine output more than 3 liters per day. You will check the urine osmolality. If the urine osmolarity more than 300, so there is a solute diuresis, as we mentioned, or it may be renal solute defect, and I will tell you how to surely diagnose solute diuresis. If it is less than 300, we will divide it into two categories. Urine osmolarity less than 100 milliosmol per kilogram. Sure, this will be a highly diluted urine. This sure is a water diuresis. But if the patient urine osmolarity is between 100 and 300 milliosmol per kilogram, so this is a mixed polyuria. The patient may has combined water diuresis and solid diuresis. So if it is totally due to water diuresis, they may be due to sarcogenic polydipsia or diabetes insipidus. Mixed polyuria may be in partial diabetes insipidus, chronic kidney disease, simultaneous water and solid intake. This is a mixed part. And if it is solid diuresis, so more than 300 millimole per kilogram, so the cause mainly is due to high solute level in the blood, whatever is due to hyperglycemia, azotemia, as in case of urea in obstructive cases. So in post-obstructive diuresis, you will find a high urea level in the urine, or due to high solute intake, whatever due to intravenous fluids, parenteral nutrition or intranutrition, or exogenous supplements. If the patient has urine osmolarity less than 100 or between 100 and 300, you have to make water deprivation test to differentiate is it diabetes insipidus or other cause, and what is the type of diabetes insipidus. And if the urine osmolarity is more than 300 or between 100 and 300, you have to collect urine osmoles to estimate what is called urine osmol excretion that I will mention to you now how to use to diagnose. So as in this approach, you will see that if the urine osmolarity between 100 and 300, you have to do both water deprivation test, and 24-hour urine collection. In this case of water deprivation test, how we make the water deprivation test, this is a critical test. The patient must be admitted. There must be at least an hourly examination of the vital signs of the patient, because the patient may become dehydrated, severely dehydrated, which may be dangerous and may be fatal in some cases, especially in old age. Usually, the water deprivation test done over about 6 to 8 hours, maybe 9 hours, or you can make it or terminate the test depending on the loss of body weight. You will restrict the water intake until the patient loses 3% to 5% of his body weight, or until 3 consecutive hourly urine osmolarity are within 10% of each other. No change, no major change in the urine osmolarity between 1 hour and the other. After the patient finishes his deprivation period, 6 to 8 hours, or according to the loss of body weight, you will give the patient vasopressin about 5 units subcutaneously, and you will measure the urine osmolarity again through all the hours. This is a follow-up sheet. You have every hour to measure the patient weight, the urine volume, serum osmolarity, and urine osmolarity. Because in this sheet, your decision to terminate the test will depend according to this change on the body weight or the change in the urine osmolarity. We make this test mainly to differentiate between central diabetes insipidus, peripheral diabetes insipidus, primary polydipsia. Diabetes insipidus causes may be central. There is an impaired release of ADH release, which in summary may be related to any injury to the pituitary gland, posterior pituitary, due to trauma or post-operative states, tumors or infiltration, infection, and cerebral vasculitis. While nephrogenic diabetes insipidus, the pituitary is normal, but there is a resistance to ADH release, This may be congenital or maybe drug-induced, and the most common is lithium, maybe other drugs. There is a resistance in the kidney for the effect of EDH in case of hypokalemia and hypercalcemia, and we will talk about these later in lectures of hypokalemia and hypercalcemia, and also maybe due to tubular interstitial disease. And by the way, as we consider now drug-induced diabetes insipidus, I have to mention also that there is drug-induced hypernatremia. Many drugs that we are using, in their chemical content, there is a high volume of sodium. For example, one of the most common used drugs that we use, ciprofloxacin. So if the patient has a persistent hypernatremia, although for exclusion of all other causes, please make your clinical pharmacist to check the sodium content of the drugs of the patients. Maybe one of these drugs is the cause of hypernatremia of the patient. Back to the water deprivation test, we will compare between the urine osmolality before the vasopressin administration and after we give the patient vasopressin at the end of the deprivation period. Normally, the urine osmolality will be high if the patient has normal ADH release, if he has sarcogenic polydipsia, he is totally normal regarding his ADH physiology. So if he is deprivated for a long period, the urine will be concentrated. More than osmolality will be more than 120. In some texts, they mention it maybe more than 800. You will find it concentrated. And once you give the patient desmopressin, there will no be increase in urine osmolality as the patient is normally has normal ADH with maximal activity. So more excess of ADH will never give more response. In cases of complete central or nephrogenic diabetes insipidus, complete, so there is complete absence of the effect of ADH, whatever, because it is completely absent from the pituitary, or there is a complete resistance for the ADH release. We will find here urine osmolality below 290 millismol per kilogram. You will find the urine is diluted. And actually you find it below 100 millismol per kilogram. And once you give the patient desmopressin, this will make you to differentiate between the central cause and the nephrogenic cause, peripheral cause. Because if the cause is due to deficiency of ADH and the kidney is normal, once you give the patient vasopressin, the urine osmolality will increase. It will rise by 2 millismol per kilogram water, and usually it will be above 500. But if the main cause is due to resistance in the kidney, there will no change in the urine osmolality. The same we will have in the diagnosis of partial central or nephrogenic diabetes insipidus. But here, before the deprivation, we will find the urine osmolality. Sorry, there is a mistake in what I said. This is not before the deprivation, here or here. This is before the administration of desmopressin. I mean, this is at the end of the deprivation. Here, at the end of the deprivation, the urine volume, the urine osmolality is 1,200. Here, at the end of the deprivation, before giving desmopressin, the patient osmolality will be 290. Then after giving desmopressin, it will increase. Here, at the end of the deprivation, the urine will be slightly concentrated in relation to the complete cases. You will find the urine osmolality between 400 and 500, but it is not normal, because normally we said it must be concentrated more than 800 to 1,200. And you will differentiate between central and peripheral part. You will give the patient desmopressin if the urine osmolality increased, so it is a central diabetes insipidus, and if not increased, no change, it is a nephrogenic diabetes insipidus. Rapid enumeration, copeptin. Copeptin is a 39 amino acid long peptide, which is derived from the C-terminal of pre-vasopressin. Pre-vasopressin is the pre-hormone of vasopressin. So measuring of the copeptin may reflect the level of vasopressin. And there is a practical approach, but actually it is not available in my country, copeptin. I don't know where it is available worldwide, but usually, actually, there is a pathway according to diagnose diabetes insipidus away from deprivation just by measuring the copeptin level. And according to the copeptin level, you can diagnose the type of diabetes insipidus. Back to our approach. Now we finished the talk about water deprivation test. Let's talk about what is the benefit of collecting urine osmoles. Collection of urine osmoles makes you suggest or diagnose that polyuria may be due to high solute intake. As I will show now to you the equation, if the urine osmole excretion per day is more than 900 milliosmol per day, this will diagnose a high solute intake. How we calculate the osmoles per day? You have to measure the urine osmolality and you multiply it with the urine volume. So you will calculate, so you will measure the urine sodium, urine potassium, urine glucose, urea nitrogen. You are not in need actually for other osmoles. And you calculate from those the urine osmolality. Then you will multiply them by the urine volume. If this multiplication is more than 900 millismol per day, so there is a high solute intake. This is a case that I suggested to you to read. It was about evaluation of polyuria, the role of solute loading and water diuresis, about the female that I mentioned before, that she was misdiagnosed as diabetes insipidus, but later it was discovered that it is due to high solute intake. As you see here, they measured the urine sodium, potassium, etc., and they found that the osmolality of the case was 209. That was a polyuric case. So the urine osmolality was between 100 and 300. Okay, this is very important. And then they multiplied 209 by the urine volume of the case, which was 7.8, and the urine osmoles was more than 1,630. And finally, they diagnosed it. They diagnosed the case as solute diuresis. And if you want to be sure about that it is due to solute diuresis, you can measure the osmolality of the urine. Here we calculated it. And then you have to subtract the measured from the calculated, as here. The measured was 1,630. The measured was more by 39 osmoles, which will be equal to the hidden osmoles that the patient increased their intake in her diet. So now we answered the most difficult question of the 4 questions, which is the patient hypernatremia related to water deficit or gain of sodium? And from that question, we went through our approach. Okay, so we now have a patient with hypernatremia. We know the cause. What will be the management? The first line of management, or the first option of management, is to treat the cause. Once the cause is clear, you have to treat it. But also we have to correct the hypernatremia itself, whatever the etiology of it. So the first line of the management, which is question 2, we have to calculate the water deficit of this patient. How much water we will need to correct this hypernatremia. And by the way, if the hypernatremia is related to water deficit or gain of sodium, in both cases we will treat mainly the patient with increase the water intake of the patient. So we have to calculate the water deficit of this patient. How much water he needs to correct his hypernatremia for 140 milliequivalent per liter. So now we want to know the water deficit of the patient. To calculate the water deficit, you will use this equation, the previous total body water of the patient, and will be multiplied the actual sodium over the desired sodium minus 1. The actual sodium over the desired sodium minus 1 shows you the percentage of the increase in sodium that we multiplied by the previous total body water. This will give you the water deficit. Back to our patient, let's apply this equation on him. The actual sodium of this patient is 168. The desired sodium, as I said, it may be 140. Some texts say that it may be 145. Actually, I will use here 140 milliequivalent. So if we compensate in the equation, it will give 8.4 liter. So this patient needs 8.4 liter of water, okay, to correct his sodium from 168 milliequivalent per liter to 140 milliequivalent per liter. An important point to consider, the patient replacement fluid will not only the water deficit, because as I will mention later, you will give this water deficit over a long time, over many hours, even days. So there will be an ongoing loss of water by the patient through his stool, sweating, urinary, whatever. So you have also to replace this water loss beside the water deficit that the patient needs. There are three ways to calculate the water deficit, to calculate the ongoing water loss of the patient. First, you may make it rough estimation that sweating and stool you have to replace about 30 to 40 milli per hour, and urinary use about 50 milli per hour. So totally we are talking about 80 to 90 ml per hour to be replaced roughly. Another way that mentioned in the Handbook of Critical Care Nephrology book this year, first liter of the patient, ignore first liter of water loss or urine loss, ignore it, okay, don't replace it. The second and third, from 1 liter to 3 liter, here is a 2 liter increase, replace the half, only 1 liter, and after 3 liters, replace every liter by liter. For example, if the patient is losing 6 liters per day, first liter ignore, don't replace. Second 2 liters, replace only 1 liter. And every liter after the 3 liter you have to replace. So from 3 to 6 you have the 4, the 5, the 5 and the 6 liters. So you will have replaced 3 liters. So totally you will replace 4 liters of real water beside for the ongoing loss beside the water deficit of the patient. Another way, which is more complicated, and we mentioned that equation maybe before in the management of hyponatremia, is to calculate exactly the electrolyte-free water clearance of the patient, which is calculated by multiplying the urine output by 1 minus urine sodium plus urine potassium over serum sodium, but this may be more complicated and not practical as the previous ways. So now we diagnose the cause of the patient, of the hypernatremia of the patient in question 1. We calculated the water deficit of the patient. Question 3, what the best fluid type that I can use to replace the patient needed water? Is it oral tap water? Is it saline? Is it half normal saline? Is it dextrose? What is the best replacement fluid? Actually, the replacement fluid will depend somehow on the volume status of the patient. If the patient is hypovolemic, as we mentioned before, also in hyponatremia, if the patient is hypovolemic, especially if there is a circulatory, neither circulatory shock or very hypotensive state, so the main target of the management is to correct his volume status, whatever his electrolyte state. So if the patient has frank circulatory compromise until hypovolemia, in cases of frank circulatory shock, or frank circulatory hypotension, we have compromise until hypovolemia improves by isotonic saline. Then, after his blood pressure is improved, we have to calculate water deficit and then replace water deficit. Replace it by what? I will say now. If the patient is euvolemic, directly you have to calculate water deficit then replace. If the patient is hypervolemic, you have to calculate water deficit then replace, and here you have to add furosemide, because in hypervolemic patient, the patient gains sodium. So you have to remove excess sodium beside giving the patient the water deficit. So you have to use diuretic. So you will find that beside the calculation of water deficit and replacement, in case of hypovolemia, if the patient is shocked or severely hypotensive, you have to replace with isotonic saline. And in hypovolemic cases, you have to remove excess sodium by diuretic. So what is the answer of what is the best replacement fluid? Actually, it is pure water, enteral water. But if the patient has a contraindication to water intake, or the patient can't drink, whatever the cause, you can use dextrose 5% water, or even in some references, you can use half normal saline. So this is the best ideal fluid for replacement. Back to our patient, to apply question 3 on our patient, what is the fluid of choice? As we mentioned before, that this patient has postural changes and hypotension. While he is sitting, his blood pressure is 80/60. So we'll replace at first with isotonic saline till his blood pressure improves. Then we can use other forms of fluid replacement. So now we answered 3 questions, and we have the following data related to our patient. Number 1, from the answer of question 1, we know the cause of the hypernatremia. From question 2, we calculated the water deficit of the patient and how many liters of fluid intake he needs to correct hypernatremia. And question 3, we know the fluid that we will use to correct the hypernatremia of the patient. The most important is question 4. What is the rate of the infusion that I will use to correct hypernatremia? On how long time I will correct his hypernatremia? For example, our patient, we said that he has a water deficit of 8.4 liters. On how much time I will infuse these 8.4 liters of fluid? To answer this, we have to answer question 4. What is question 4? We have to estimate the reduction in serum sodium if 1 liter of fluid is infused over 1 hour. This is what we have to answer. To answer this question, we have to talk about first the rate of correction. And again, this will depend on is the hypernatremia is acute or chronic. As we mentioned, in hyponatremia, there is a difference in the rate of correction of hyponatremia between acute and chronic cases. Actually, or generally in acute cases, we are more aggressive in the management in comparison to chronic cases in general, because chronic cases, as we said, the body adaptation is slow. So for correction of chronic abnormalities, we have to be more or we have to correct it more gradual, so that help the body to gradually compensate the correction. In cases of acute hypernatremia, correct the serum sodium an initial rate of 2 to 3 milliequivalent per liter per hour for 2 to 3 hours only. So 2 to 3 milliequivalent for 2 to 3 hours. And maximum 12 milliequivalent per liter per day. Don't correct the hypernatremia, don't decrease the sodium more than 12 milliequivalent per liter per day. In cases of chronic hypernatremia, you have to be more gradual. Correction must be at a rate not exceeding 0.5 milliequivalent per liter per hour and total of 8 to 10 milliequivalent per day. And you have to measure serum and urine electrolytes every 1 to 2 hours. But there is a recent study in 2019 about the rate of correction in chronic hypernatremia. They tried to correct the chronic hypernatremia at a more rapid infusion rate. As we said here, we haven't to exceed 0.5 milliequivalent to have a total correction of 8 to 10 milliequivalent per liter. In this study, they had 122 patients an admission. They were diagnosed as chronic hypernatremia, and 327 patients had hospital-acquired hypernatremia. 128 from them had chronic hypernatremia. And they compared rapid correction versus slow correction. Slow correction less than 0.5 milli equivalent per liter per hour that we mentioned in the previous study, and more rapid correction. The rapid correction targeted to correct sodium more than 8, more than 10, and even more than 12 millimole per liters per hour per 24 hours. And finally, there was no any statistical significant difference between the rapid correction and slow correction regarding all outcomes of the patient. So this may make us correct the sodium more rapidly in chronic cases, but I think that may be individualized according to the symptoms of the patient, etc. But in general, use the wisdom in the management of your patient. Again, why in chronic cases we are trying to correct the abnormality slowly? As we mentioned before, this is related to the slow brain adaptation to the chronic changes. Normally, what happened in cases in hypernatremia? In hypernatremia, what is the normal response of the brain? We mentioned at the beginning of the lecture how the hypernatremia developed and how the brain shrinks. The brain, to adapt hypernatremia, the brain wants to increase its size again. So the brain, at the start, its immediate response, the brain tries to increase intracellular electrolytes by limiting the loss of intracellular electrolytes as sodium and potassium. This will help to increase the osmolarity as possible in the brain to prevent more water loss from the brain. And the later response, the brain will increase its content of organic solutes as inositol, glutamine, glutamate, taurine. This will increase more the tonicity of the brain and decrease the water loss from the brain. But this adaptation is the same adaptation, by the way, that we mentioned in hyponatremia, but in the opposite side. Here in hypernatremia, the brain trying to increase the content of its content of the organic solutes and electrolytes, while in the hyponatremia, the brain tries to lose more of these chemical compounds. So as this adaptation is slow, the correction must be slow to give enough time for the brain to correct its intracellular content of the osmolytes and electrolytes to avoid osmotic demyelination. Osmotic demyelination syndrome can happen in rapid overcorrection of hyponatremia and rapid overcorrection of hypernatremia too. Back to our patient. We decided to give the patient saline. Before we calculate what will happen from the saline, how we will estimate the reduction in serum sodium for every 1 liter of the fluid we will use in 1 hour. We will use the same equation we used in hyponatremia. Change in the serum sodium by any liter of a fluid in 1 hour equal infusate sodium minus serum sodium over total body water plus 1. And as we will use dextrose or abnormal saline or saline, we have to know the sodium content of each. Dextrose sodium content is 0 as tap water. Abnormal saline, the sodium content is about 77, and 0.9% sodium chloride saline, its sodium content is 154. So we have to use these contents in the equation to know the change in serum sodium. Let's go back to our patient to apply this. And this patient, we decided to give, as we discussed before, normal saline. So let's compensate in the equation. We will have normal saline, infusate sodium here is 154, so 154 minus the serum sodium of the patient, which is 168 over the total body water plus 1. This will give minus 0.33. Always the result here will be by the negative charge. This means that every 1 liter of saline, which will be infused over 1 hour, will decrease the sodium level of the patient by 0.33 milliequivalent per liter. So now you have, let's say here, in this patient, we know that the patient needs 8.4 liter, and we know that every liter from the patient will decrease the serum sodium by 0.33, and we want to decrease the patient. The patient here has acute hypernatremia, so we can decrease only 12 milliequivalent from 168 over 1 day. So now you have all the numbers that you can use in a cross equations to calculate the rate of infusion for your case. To finalize, it is important to emphasize that the calculation of deficit is only an estimation, or the calculations or the equations we are using are only just estimations. So the measurement of the plasma sodium frequently is important, because although you are calculating the infused volume, the rate of correction, there is a possibility for overcorrection or undercorrection of hypernatremia. Because I said all these equations are just estimation based on several assumptions. So it's better to monitor the plasma sodium at least initially every 2 hours, maybe with more correction or more stabilization of the case, the measurement may be at less frequent intervals. I hope that the lecture was practical and clear. Thank you for watching, and to see you in the next lecture, and goodbye.